Welcome to 3D Players, the podcast where we explore personalization in healthcare through advancements in 3D technology. We'll talk to leaders championing more predictable and sustainable patient care. I'm Sebastian de Boot, joined by my co-host Peter Slagmolen. Today's discussion will center on standard and personalized devices, artificial intelligence and engineering in personalized healthcare. Our guest, Dr. Thomas Kofod, is chair of the Department of Oral and Maxillofacial Surgery at the Rigshospital in Denmark, where his team focuses on corrective and reconstructive surgery, as well as computer-assisted surgery. He's a strong believer in personalized care, having treated more than 1,000 patients with personalized devices, and he uses 3D planning with 100% of his patients. Welcome, Thomas. You're one of the biggest supporters of personalized care who we know of, so we're very excited you can join us today.
Thank you very much for having me.
Thomas, I'm curious, can you take us back to the first patient you ever treated with a personalized device? How was that experience?
I believed in the beginning that it would be something that we would do for specialized cases. So the first case we did was a cranio-facial case in which we planned a frontal-orbital advancement. From that first surgery, it changed the way we look at cranio-facial surgery, and we have planned all cases since that, simple or complex. So I think actually what it is that you open your eyes for how, not to say how poor, but despite the fact that you do your very best, the quality of care that you can deliver using personalized planning and implants and guides, it just shows very effectively that you can't do it without. And if you are to be honest to yourself, you have to realize that quite early. And therefore also the change of discussing where you do it in some cases or you do it in all cases is quite easy, I think.
And maybe for the listeners not experts in your domain, can you explain what that procedure entails in layman's terms?
Yes, it's a correction of the shape and the potential size of the cranium of children which is born with a growth anomaly in which the growth zones of the cranium fused before birth. And therefore they have a constriction of their cranium and the volume in which their brain can develop. It's not a rare disease, but it's a fairly rare disease, and it can be either simple or complex, in which more of these growth zones, which are called sutures, are closed.
So what was then the primary motivation for you to choose, on this particular case, a patient-specific over a standard device?
In this case, it was the computer-assisted surgery, the ability to plan and design guides and osteotomies in which we could develop a treatment plan and a treatment for this child. And prior to this, it was more or less handheld. You were moving bone still with some osteotomies, but there was no pre-planning. So despite the fact that in many years we have done pre-planning in reconstructive surgery and we've used stereolithographic models for bending plates, then it was the first time we actually did osteotomies prior to the surgery on the cranium. So all the small bone cuts, everything was guided, and we were able to reposition this using resorbable osteosynthesis. And with the experience we have now developed together with good colleagues, engineering colleagues, is a very nice total setup for personalized care in these children. So we can actually develop a nice design. We have guides both for the actual bone cutting on the cranium, but also for the repositioning of these bone parts and the repositioning. And most of all, also trying to change the care of these patients by starting the change where we blow up a balloon inside the cranium, and therefore we can measure the changes that is possible with the care we now do. And that hasn't been possible before because nobody knew what they were doing actually. We were moving bone and it looked fairly nice, but nobody knew the planned volume prior to the surgery.
So it's actually since then also changing the kind of procedures that you're doing then?
Sure. I mean, there's no going back. You see immediately it shortens surgery, it's more precise, and it's more predictable. And of course, this is with they have the age of 6 to 9 months old, and it's a very strong tool to be able to tell parents that we are going to correct the child's head, your child's head, and it's going to be this plan. I mean, it's much easier to discuss the actual treatment with patients, not just parents to children with this disease, but in general.
Mm-hmm. So you're describing that the impact of using this personalized approach is not only on yourself as a physician being better prepared, but it's also on how the patients and their parents and their family can go into this surgery, right?
It affects all of us. So it's a change of the way we think. We can plan all surgeries. It's not something we develop during surgery. And there is no excuse not to plan prior to surgery. There is no good excuse why you shouldn't plan. If you come up with something that doesn't fit, then it's your insufficient plan. I mean, you can plan everything. So it's not just to say it puts pressure on the team to develop and to figure out both the plan, but also within that plan, a rescue plan for oncology, for example. It's just our ability, but I think in general, everything can be built. It still is a clinical decision what determines the surgery, which it should be, but it's built in a strong collaboration with especially engineers, and then it changes the full team and how we produce and treat patients.
Mm-hmm. Again, zooming back to that, to the more early days, let's say, and maybe you can also explain us like how many years ago that was, just to get a little bit of an idea. What were some of the hurdles and challenges back then?
It's a little like this, that if we go really back, I started in this specialty and I was cutting stereolithographic models back in the end of the 1990s. We were building models, we were cutting still something. But the idea that we were then just ordering a model with no real knowledge to put in what was the size of a tumor, which needed to be resected. But then we just cut the model and we tried around and bended plates. But having the ability to be able to operate the patient prior to the actual operation and plan several outcomes and figure out what is the best possible outcome for this patient. Now with the planning phase, we still go back to 2012-13, in which we started with computer-assisted surgery. But now you could say in this way as we have done it. And then, of course, there's a big change by the use of patient-specific implants when they came around. So still it was improved care, but it was not the real change, because the real change comes with personalized implants. So, of course, you can produce guides in many ways. What becomes even more, you could say, visible is our ability to actually perform those changes that we need on the skeletal level without patient-specific implants. We can bend plates, we can do a lot of things, and we can come fairly close. But the precision in which we can treat now with patient-specific implants is a total difference to what we used to be.
So it's finally, let's say, the first time you can actually really do what you would like.
Yeah, but we all thought we were doing a great job. In general, we are doing a great job, but it's just we're not doing a perfect job. And there's a much closer to perfection in terms of precision.
Yeah.
So if it's the right plan and the right implants are produced, then it can come very close to perfection in order to reconstruct correct craniums.
Can you explain what's the difference between a good and a perfect surgery for the patient?
In many corrective surgeries, we move jaws around in order to correct either two jaws being too long behind or too long forward, or having a asymmetric face. And if we're doing a real good job back then the precision on the positioning of the upper incisors was a couple of millimeters, 1.5 millimeters to 2 millimeters in any direction. So it would be a midline being off by 2 millimeters. Now that midline precision would be closer to 0.2 millimeters in any direction with a patient. So, I mean, it goes without saying, it's extremely more precise.
And the reason that precision is important, specifically in cranial surgery, is that mostly because of the aesthetic impact of such precision?
Well, it's just not the aesthetic. If you operate on lengthening legs, we all have shorter and longer leg, and we wouldn't even know. So until a couple of centimeters, it doesn't really bother us. But if we put a hair between our teeth, we can feel that we have a hair. It's 5,000 angstrom, so extremely thin, and we can feel that. So the precision needed in the correction of craniums is much higher.
Nice. That's an interesting view. And maybe I'll jump to something I wanted to ask later, but is that also the reason that you believe that personalized care is so much more advanced in the cranio-maxillofacial space than it is maybe in other domains because of that sensitivity?
Well, in the specialty, there's been a tradition and need for real close planning. So I think in general, we know that the precision needs to be much higher. But the idea that you actually pre-plan surgery has been there for orthognathic surgery, the correction of jaws, moving them back and forth. I mean, it's fairly the same way we have planned them for 50 years. The ability to do it in the computer come with extra treatment designs, and especially the translation into this. I mean, we have planned always, and therefore we also advanced with the use of computers much faster than other specialties, because you could say there was a culture and a tradition to go and see what we're supposed to do. If you go to orthopedics, well, now patient-specific solutions are coming up, but it's more or less 10 years later than CMF. So I think, but it comes with a tradition and a culture which wants to improve care all the way. It's not that orthopedics don't want to improve care, but that there has been an understanding on the possible changes with computer-assisted surgery.
Mm-hmm. Are there any lessons learned, you think, for those other in domains like orthopedics that can be had from CMF to?
For sure, they don't need to go through a 10-year period in order to figure out what to do. But I think we need to be able to visualize what we are doing, and that come with improved software. Then I think it should be possible that we segment that doesn't matter whether it's a fracture patient or an oncological patient, because then we would need what we need to resect. Of course, with the advanced, in the future will be that we actually can monitor growth of tumors, because then we would know how much we would resect. And the ability then to go into a software in which you can visualize a tumor on one or two modalities and do a surgical planning, and afterwards get a patient-specific implant and a patient-specific plan for a graft or just an implant. Mm-hmm. I mean, that ability is, they don't need to develop that in other specialties. It's fully transformable into orthopedics for tumor care or for different. And I mean, what there is in CMF is, I mean, it's done within neurosurgery. I mean, it's not a CMF discipline. We do it combined with the neurosurgeons. Within cranio-maxillofacial traumatology is also done by neighboring specialties. And some of them have no tradition, but it will change these specialties too, plastic surgery and ENT. And likewise for oncological care of head and neck tumors, it will change those specialties too, because there's no, I mean, in the future, there will be nobody who enters this kind of situation and don't ask people, could I see the plan for my operation, doctor? So I think there will be that need.
Obviously, you're a big supporter of personalized planning and potentially also guides and implants. So yet, I guess also in the CMF domain, it's not that every physician is doing this, I'm assuming. Like, what do you think are the reasons for that? Like, what are still some of the bigger challenges that exist?
There's always a discussion that planning is expensive. You shouldn't need to reoperate that many patients in order that it's much cheaper to do it right first time. So there's a discussion which is about pricing and is it expensive? And when we changed from stainless steel wires onto plates, everybody thought it was too expensive. Now everybody thinks it's fine with the pricing. When we changed for resorbable osteocenses, then everybody said, oh, it's expensive. But with more and more people using them, the price goes down. And we have used 2 or 3 other 2D systems for planning orthognathic surgery. If we look at the time spent to cut plaster models, look at X-rays, tracing X-rays in 2D in relation to do it in 3D and with the possible outcome of that, it's not for discussion. It's about moving money from one system to another system and understanding that change. And of course, we live in different societies all over the world. If it's an insurance-based healthcare system, they look to make an economical outcome for those owing the insurance companies. But in general, it's true to say that most of the patient-specific implants of this kind used has been in a public hospital in Central Europe and a private practice somewhere in the Oceanic. So it doesn't have to do with the setting we are in. It has to do with the actual understanding that this is a need. And of course, within CMF, it's like this, that our culture has been that we think we should be cheap. I mean, every time a solution came up, we thought we should be cheap. I've seen neighboring specialties, nobody think they should be cheap. I mean, everybody knows that in spine surgery, it costs a fortune. In pelvic surgery, it costs a fortune. So we just need to realize that if we want to still going on being cheap, then actually we are not understanding the needs of our patients. And of course, we need to understand that change. And it's not because it needs to be expensive, but of course, with a growing market, the price will go down. It's always like this. But in general, it's also about accepting that we are improving care, and improved care costs money.
Am I right in assuming that you believe that in the end it's not more expensive, maybe, that it's more a shift from what we did traditionally towards new, more digital methods, but then in the end the overall cost is not going up? That is maybe a misconception of the people?
I think by far that's true. I mean, of course, there'll be a short-term shift in that the actual implant is more expensive. But if you see operation time shortened in theaters where you do free flap surgery, just using these kind of guides and implants shorten 3 hours. And it's by far paying for the price of the guides and the implants and all of that. So for me, no doubt. But also it's a change. In the old days, I was sitting in the morning cutting plaster surgery and tracing X-rays. Now I have a daytime, mostly, a daytime planning with an engineer, and the outcome is much better. I'm changing, not doing 3 hours or an hour and a half of cutting plaster and making models for pre-planning to surgery. Now we do something which is better. Mm-hmm. And of course, we buy some of that. And of course, that has a price.
You mentioned here the role of the engineer. I'd like to pick in on that a bit. Can you explain what the engineer, what do they do exactly? And what's the contribution of an engineer today in your procedures?
So from the very beginning in the early 90s, late 90s, it was actually that we ordered a model and then they were producing a model and we got the model. But now it's a very close collaboration, mostly every day. And they take care of a lot of the things that's needed in computer-assisted surgery. There's a lot of, you could say, segmentation of data set, pre-producing, ready for a planning session. We have now on-site planning, the possibility for that, but we have for many years have these virtual planning meetings. We have pre-ordered, we have told them what kind of surgery we would like to perform, and therefore they have made everything ready. And then we have online, you could say, a planning session in which we align the face as we have seen the face clinically. We go through the needed planning, the needed movements of that. And then post-planning, there's a lot of processing of building guides, building implants, and designing all of that. So they do a lot of what doctors and lab technicians do. They produce a lot of this. It's done, of course, now on a computer, but there's still a lot of manual work also still being done post-processing. But in general, this is the daily work, and they take care of a lot of the work that we were doing. So it's our closest collaboration now, I think.
What the listeners don't know is that you're a bit special in a way that you have your own engineer on site at this point in time. Can you explain what value that brings additionally compared to maybe somebody who is remote? What's the difference for you in being able to have somebody to work with on a day-to-day basis?
It goes without saying, it's for this very long collaboration, I think it has changed our daily work. I mean, we plan a lot of patients, but we also develop care. We have developed a lot of different treatments, algorithms, modalities, designs, stuff like that. And that's much easier when you sit together. We can discuss different things, but the ability to change how we see what we would like to do with computer-assisted surgery, and that collaboration goes without saying, it's much easier with somebody on site. Mm-hmm. It's not that we haven't developed things together being, you could say, through the screen, but it's something very different.
And we do see also with the actual manufacturing, so the production through 3D printing of personalized devices, you see this shift going on of something that was happening in companies exclusively towards hospitals doing this at the point of care. What do you think is the driver behind that shift? Is that also what you just mentioned, the collaboration, or are there other things at play?
There'll be a couple of ways. I think if you discuss what in some hospitals they would need something which is an on-site planning or printing facility for some products. I don't see metal implants being produced, and I don't see the change towards resorbable new implants being produced at hospitals because of many good reasons, but among others because it's potentially explosive and stuff like that. So there's a lot of handling which needs to be taken care of. What we need to understand is where we can meet each other best. It would be for CMF that for acute care, we would need a printing facility to print an orbital implant for an acute trauma day 1, 2, 3, 4, but we can actually have personalized implant day 5 or 6. So we will develop care, and if we couldn't have had a orbital implant day 5 for the reconstruction of an orbit, of course, then we would need to have, you could say, to develop. But it's with the effort of logistics, a lot of a long-term working relationship and an understanding on which are the needs in order to treat patients right. Mm-hmm. I mean, there will be, for oncology, we now can get reconstructions planned, produced, delivered with reasonable time in order to live up to the packages from oncological care. The same with the orbital implants. Of course, we can't have a patient-specific implant produced within 6 hours, but we can have then somebody that can guide the shape of a standard implant, which would be second best, and then the possibility to use navigation or likewise in order to control our treatment.
That's an interesting view. So what you're saying is that you have actually, probably because of technology advancements, you've had a lot more options now to do personalized because it's become fast enough for certain indications. Are there indications today where you still are forced in a way, that's the way I would describe it maybe, are forced to revert to a standard approach where you cannot rely yet on personalized? And which cases is that and why?
There is, for example, a gunshot wound and we would need to reconstruct that, a soft tissue damage, and we would need to realign that mandible, then we would need a reconstruction plate. And we can't have that, prior to 8-9 days with a decent. But what is then, we can then have a model almost a day after, 2 days after, and then we can bend a plate on that, and we can even have guides to do that. Again, that's logistics and a huge change in the production, which is guided towards the need of treating patients, even with acute care. We still use computer-assisted surgery. We still pre-bend the plates. We still guide the position. It's just that we can't have the implant produced with the same speed as a polyamide or an acrylic guide. So this is how it is. And I don't think we will have 6 24 hours implants. So there will be a need in order to have, you could say, something to print an orbit, to print a mandible, whether that's on site or with logistics within 2 days. I think that's how patient flow develops in the local setting, but for sure. So there's a few things which still needs to be able to do, but they are hard to handle if we want a patient-specific implant. But we can still use the planning and have a patient-specific, adapted, standard implants, and that's much better than no plan.
All right, it makes a lot of sense.
Simplify your workflow to what you can do, basically, for specific indications.
On the topic of trying to simplify, I'm going to shift a bit towards innovation as well. We're very curious to hear your opinion on artificial intelligence. And I know Peter was keen on asking that question. So sorry, Peter, for stealing it.
No, that's fine.
Artificial intelligence, it's a big thing today, and it's already impacting quite a lot of things in terms of efficiency and so on. But can you explain your vision on what role you think AI will play in making your planning smarter? When would you trust on yourself as a surgeon and a trained engineer versus an AI algorithm to kind of give you a suggestion?
Well, I think it will be fine with suggestions. I think with improved care, they would know which kind of osteotomies that, for example, me as a treating surgeon, how the design should be of the osteotomies. And of course, we should see them automatically. And then, of course, it will be like this, that from the previous plans, if we put my plans on top of each other, they would potentially look quite alike. If we have a patient in which we preoperative know that these are the measurements that we would default do, and we can actually take them from the previous, then of course we can do a preoperative setting of this is how you would usually do it. And then that's another discussion. Then we always need to move them around. So for me, AI would be beneficial in order to say, well, Thomas, do you think the care of this patient should look like what you usually do, or is there any different things? So I think there will be a lot of possibility for advanced, you could say, an improved workflow, also especially on the engineering part. The same with the design. Okay, we usually do like this. Do you think would this design be the same? If AI should be used wisely, I think that we can come up. But on a longer perspective, I would also see that we have, for example, airway defining the needs. We would need to have soft tissue defining the needs. So in theory, when we have very good soft tissue algorithm from the airway, from whatever, then, for example, in sleep apnea patients, we would let the knowledge there from how do we open the airway and how much it is needed would be that we get. And we would get a suggestion that you would need to move maxilla mandible, let's say 12 millimeters forward, and that you would need to have the hyoid bone being advanced this size.
And that's then something that today is really difficult to do then, where you're looking?
Well, we are on the borders of trying to discuss this, and we do some segmentation and we move them, but we see the result post-operatively. But a little like starting the change of care in the correction of children's craniums on the craniosynostosis patients, then if we now know what we are doing, which changes we are in, and we know how much volume we are changing, then in 15 years we would know, okay, this was enough. This is correct, because everybody's discussing correction versus overcorrection. But what is overcorrection if you don't know what you are correcting? In order to be able to have that discussion, you need to plan something, and you need to be able to do that during surgery. And that doesn't really matter whether it's on top of the cranium or it's moving two jaws, unless we can trust and show that the position is correct. And these were the changes that we did. But then, of course, in sleep apnea patients, knowing that we moved them 12 millimeters and we know how the hyoid bone and the soft tissue, the tongue, palate moved, then we would know, okay, we don't need to move them, let's say 18 millimeters, but just 12 millimeters. That would be the clever use of AI also, that we improve care, not just on the movement of the skeleton, but actually foreseeing which changes are needed in order to change patient's life I mean, these get rid of CPAP machines. They don't have strokes and different other things, which is a higher risk for in sleep apnea patients. So a lot of these things. And with increased demands on what's called interfaces, I mean, it's not because we need to go that way, but we need to have a discussion on how does this change aesthetic surgery in the future. There should, of course, be built patient-specific implants for aesthetic surgery, likewise these that we do for corrective surgeries, and this should be part of the care. And if I was having aesthetic surgery by somebody who was moving or putting something on my face, for sure, I would love to see the implants and the changes needed, but we are not there yet, but we will come there. Again, with improved visualization of soft tissue, that will that be the change of care for aesthetic surgery. And then they don't potentially need 7 surgeries or 7 procedures, but potentially 1.
If you look forward 20 years from now into potential better ways of treating patients, is there anything that's impossible today that you would love to be reality by the time that you can retire?
For a lot of the things that I think will be needed is that we get rid of a lot of the lovely titanium that we put in patients now. I think we should where's the need for a permanent implant and where can we use resorbable implants and which part of the implant can resorb, so we don't need to do additional surgery. Some of the understanding and really put pressure on that we have still development, despite the fact that we now have a good platform for moving things around, is that we should make those implants disappear again. So that would be one thing that I think will need to change. We have some of the possible implants, but we need to develop new materials for new implants. There is still things. What I hope we can do is that we can learn to visualize tumors better and therefore also mark them and use the computer-assisted surgery in order to make improved care. I hope that we can mark tumors and also their displacement on the soft tissue so we can plan proper with radiotherapy. So that will be in one solution, not in 2 solutions. I think what happens is that we have not enough or not good enough visualization markings of tumors, and we therefore resect too little or too much. But the ability to see, visualize the tumor, make a perfect plan, having a fast care, and then I think that will make improved care and also this higher survival of head and neck surgery, for example, but any surgery as such. And then, of course, there is nothing that can be planned for elective surgery. I don't think there's a need not to use this kind of planning. The other thing is that you actually need to treat fewer patients in order to become good at the surgery because you use your brains pre-op and there's a possibility to use this information post-op. So any surgeon can make multiple plans, plan for one surgery, and see how good were we at accomplishing this. That knowledge needs, of course, with AI to go into the system, that this is a better design. At the moment, it's a little like we think that one design from a clinical perspective is good. We have been doing that for years. It works fine. From an engineering point of view, they think they know, but it's good for a technical point of view. And of course, that needs to meet somewhere in the middle. So we actually know that this is a good design. And for these and these reasons, we can go closer, for example, with screws towards teeth, because we actually agree that who is at risk, that's the patient. And it's not the engineer trying to make sure that the screw don't come close. It's not the surgeon, which is over-aggressive, but in that dilemma, trying to make it work. And of course, their engineers and surgeons or alike needs to meet and discuss these matters so it becomes real what we are doing.
Great. I think that's a perfect note also to end on, is the synergy between engineers and surgeons, which is a great part of your story. Thanks a lot for joining us, Thomas. I think what I take away is your experience on the importance of surgical planning for cranio-maxillofacial surgery. What I liked was how you described that you should probably stay away from potentially explosive technology within the hospitals and what innovations can bring us Instafaces in the future. That was all pretty interesting. So thanks a lot for sharing that. We really appreciate your insights with us on this 3D Player podcast, a podcast where we explore trends, insight, and innovations in personalized and sustainable healthcare. We were your hosts, Sebastian de Boot and Peter Slagmolen. Thank you for listening, and please join us for the next edition.